It's 8 o'clock. Good evening, everybody, and welcome to today's episode of Marvelous Medicine. Today's topic is respectful maternal care. We have two eminent speakers with us. Dr. Manju Puri is the Director Professor of Obstetrics and Gynecology at Lady Hardinge Medical College, New Delhi. She did her MBBS and MD from the Postgraduate Institute of Medical Sciences, Rohtak. Dr. Puri is the Chairperson, Safe Motherhood Committee of Association of Obstetricians and Gynaecologists of Delhi. She is the National Coordinator of Practical Obstetric Committee of FOGSI and the President of the National Association of Reproductive and Child Health of India, Delhi. Dr. Puri's field of interests are high-risk obstetrics, reproductive endocrinology, and quality improvement. She has edited 3 textbooks and is an external quality assessor for public health facilities. Thank you, Dr. Manju Puri, for accepting our invitation and joining us at such short notice. Second speaker will be Dr. K. Aparna Sharma. She is the Professor, Division of Maternal and Fetal Medicine, Department of Obstetrics and Gynecology, All India Institute of Medical Sciences, New Delhi. Aparna did her MBBS from Institute of Medical Sciences, Banaras Hindu University, and her MD in Obstetrics and Gynecology from Maulana Azad Medical College, Delhi. She was a Senior Research Fellow in Fetal Medicine at AIIMS, New Delhi, and did her fellowship in Maternal and Fetal Medicine from Barcelona, and has expertise in fetal interventions. Aparna is the Secretary, Society of Fetal Medicine, Chairperson, Multiple Pregnancy Committee, Childbirth Society of India, Chairperson, AOGD Quality Committee, North Zone Coordinator, Safe Motherhood Committee of FOGSI, Co-Convener of Early Pregnancy SIG, Indian Fertility Society. Aparna was a Kamini Rao Orator in 2017, which is a prestigious oration for young members of FOGSI. Welcome to the show, Aparna. Moderating the session will be Dr. Mini Ravi. She is the Consultant Obstetrics and Gynecology, SSMC Mayo Clinic, Abu Dhabi, UAE, and Adjunct Assistant Professor, Khalifa University and Gulf Medical University, Ajman. She did her MBBS and MD and DNB Obstetrics and Gynecology from JIPMA Pondicherry, which is my college. And she was awarded Dr. Seshadri Pani Memorial Oration for Young Obstetricians and Gynecologists of India for her dissertation during her post-graduation. She subsequently completed her FRCOG in UK and did a clinical fellowship in operative and diagnostic hysteroscopy and also a diploma in gynecological endoscopic surgery from the University of Kiel. He is a certified manager of quality and has also done a postgraduate diploma in business analytics. He has received several awards in different categories in Abu Dhabi, and her special interests are Maternity Enhanced Recovery Program, surgical site infections in obstetrics and gynecology, and low risk ambulatory care and connected care. Maybe after the talk, you can tell me what connected care is, Vinny. Thank you for joining at such short notice. Over to you, Dr. Puri.
So a very good evening to all of you. And it is indeed a matter of great honor to be here amongst this august group and talk about respectful maternity care. Respectful maternity care is also known as humanization of childbirth. So it actually emphasizes the need to humanize birth, taking a woman-centric approach. Now, we all know that in the older time when majority of women were delivering at home, they were surrounded by their relatives, and the person who would conduct the delivery would be known to the patient. So everything was kind of warm in the comfort of the home. And ever since the women started coming to the hospitals, especially in the public hospitals, so somehow they have started delivering alone. I'm to say we don't allow birth companions. We they are surrounded by people who are not known to them. So WHO came up with this concept of, the experience of care which they receive. So it is not only about birthing safe, but it is what the woman would feel or what would be her experience like. Is it a positive birthing experience or not? I think that is what stays the focus, because that is what also, has an impact on the outcome of the mother and the baby. and the way she would progress through her labor. So WHO defines good quality maternal and newborn care as a care effective, timely, efficient, equitable, and people-centered. So one of the very important yet overlooked aspect of maternity care is respect, dignity, and emotional support using effective communication. So somewhere down the line, this particular component has kind of received a lot of thrashing, and we have ignored it. We have ignored it substantially. Good quality care has also been recognized as an important factor, which would further promote institutional delivery. So if a mother goes satisfied with the services which she receives at the facility, she's bound to motivate others to come back, to come to the hospitals for their deliveries. It also improves the birth outcomes because the anxiety which the patient would have during labor gets translated into, the hormones, hormonal changes in a body, which then get circulated to the baby and are definitely bound to have some kind of impact on the baby. And also the hormones which are produced during birth, in case she's anxious, she's stressed, they're bound to be more of catecholamines vis-a-vis the happy hormone, that is the oxytocin, and hence the progress of labor and other things are also going to get affected. It also determines the patient and her family's future health-seeking behavior. So if her experience of birthing is not positive, she is unlikely to seek help in the later times for herself and her newborn. She would be scared of coming back to the facility. So a woman's experience with healthcare providers in labor rooms can either empower or comfort them, or they can inflict long-lasting damage or emotional trauma. Now, these are certain verbatim, sentences which might sound very harsh, and sometimes one might think they may not. It's not possible that one would talk like this. But these are true sayings which have come up from the literature which is published. Something like, if the woman is asking how long will it take, how much time is she to birth a baby. So they would say, हमें पता नहीं, लेटी रहो, बार बार मत बुलाओ. So परेशान करा हुआ है तुम्हारे रिश्तेदारों ने, ऐसे करेगी तो इलाज नहीं होगा तुम्हारा यहाँ पे. Something like, इतना चिल्लाओ मत रानी, हमारा सिर दर्द हो रहा है. अगर जोर नहीं लगाएगी तो बच्चे की धड़कन खराब हो जाएगी और बच्चा खत्म हो जाएगा. बच्चा तुम्हारा ही तो है, दर्द भी तो तुम ही बर्दाश्त करना पड़ेगा. It's absolutely very crass kind of comments which anyone, it's not uncommon. It is pretty common. It is more common in public hospitals. Of course, in private hospitals, patients are not going to take this from the doctors and also from the support staff. But still, it is there in some form or the other. So this is what the reality is. And that is why we have started talking about respectful maternity care. So this was an elegant review which was published by Bauer and Hill. They looked up all the literature which was available in the form of case reports, interviews, and articles regarding the respect around or the care around the birth, and what was the experience of the mothers like. And they came across these 7 areas, categories of disrespectful care, which were there all across the world. So this was global. Physical abuse, non-dignified care, non-consented care, non-confidential care, discrimination, abandonment or withholding of care, and detention in facilities. So I think all those who are in public facilities would understand, and even in private facilities would also understand that this does happen. So they were based on this, there were 7 rights of childbearing women which were kind of proposed, and they are based on International Human Rights Declaration and conventions. So for physical abuse, for each of these disrespect categories, we have a corresponding right. So physical abuse, it is freedom from harm and ill treatment. Non-consented care, it is right to information, informed consent and refusal, and respect for choices and preferences, including the right to companionship of choice wherever possible. So women need birth alone, they should have a birth companion of their choice, whatever kind of facility it is. Non-confidential care, so the corresponding right is confidentiality and privacy. Non-dignified care, including verbal abuse, so the right is dignity and respect. Discrimination based on specific attributes, the right is equality, freedom from discrimination, equitable care. Then for abandonment or denial of care, it is right to timely health care and to the highest attainable level of health. And as far as detention in facilities is concerned, it is the right to liberty, autonomy, self-determination, and freedom from coercion. So this is the charter which was released, and these are the 7 rights. So we'll just go one by one through each of these rights. So first is freedom from harm and ill treatment. So we know that ever since women have started coming to the facilities and delivering in hospitals, the use of interventions, which is not evidence-based, has increased. So episiotomies, induction of labor, cesarean sections, unnecessary antibiotics, and say the whole lot of things which we keep doing, which are actually not desirable, and for whatever reason. So sometimes we say it is a patient who is demanding, sometimes it is for the convenience of the doctor, sometimes the doctor is not aware of that, the actual evidence-based practices. So whatever the reasons may be, but the use of interventions is what is happening, and which is not for any good of the patient. Causing physical harm during shifting the patient. Say the patient is being shifted from one place to another. If we don't take care, I'm saying there could be, she can fall off the table or things like that. Then insult, intimidation, threaten, or hit the patient while performing procedures. So, we've had people, we've had situations wherein the doctors have lost their cool. They feel that, or the nurses have lost their cool. They feel that, they're overworked. That is fine, but, there's no reason why we should hit the patient, either with the instrument or forcibly separating the legs to do a per vaginam examination where the patient is not, cooperating. So that is not desirable. So that is what is important, that first we should do no harm. That is one of the basic pillars of, the care which we are going to provide, and then not do anything which is not evidence-based. The second is right to information, informed choice, and refusal, and respect for choices. Now, say it is not about public and private again. I'm, mentioning it because, when there is a patient who is wanting a cesarean section, and or a doctor who proposes a cesarean section for a patient, elective cesarean section, it is not that we always tell them what are the disadvantages of cesarean section subsequent in the later pregnancies. So that is very, very important, that we quite often would miss out on telling them that there are chances that she can have a morbidly adherent placenta next time, which would mean she would have hysterectomy, and which would also mean that she could lose her life if she wants to have another baby, scar ectopics. There are n number of things which go with the baby being born by cesarean birth. And also the non-exposure of the baby to the maternal vaginal microbiome, all that problems which the baby can have subsequently because of this non-exposure is something which is important. And I don't think so we give all this information to the patient when we decide and we say that we are doing a cesarean because the patient is insisting that we should do a cesarean. A woman has a right to choose one birth companion to be with her during delivery, whether it is a heavy load facility or it is a private sector. It is important that no woman should deliver alone. I'm saying childbirth is something which is the most crucial time of her lives, and it is important that she should have some person, person of her choice, to be with her and support her during this process. Information and support on positions of labor and birth, fluid intake, emptying of bladder regularly, exercises for labor, early initiation of breastfeeding. Let's understand that not all these things are actually, this information is provided, and not that we support them for all these, things. It could be because there is heavy load, but I'm sure if it is useful for her, it is important that we do inform them about it. We have to find out a mechanism wherein these are their rights. And say we need to tell them what is good for them and what they should be doing. Confidentiality. Now, patient records should be kept in a secure place, inaccessible to general staff or visitors. Personal details about any client should not be discussed publicly. And it's quite often you can see people publicly discussing their patients. If you're surrounded by patients who are in the process of labor, and say when you give over, so generally you keep telling this is so-and-so patient, this one is an unmarried, she is HIV positive. So, we are casual as far as, talking about patients, personal details of the patient is concerned. Then information about the progress of labor of a woman or complications, if any, should not be stated aloud as other women may hear about it. So it is very, and even if you have a patient who is not cooperative, so you find the staff discussing amongst themselves that this patient is a problem patient. So, things like this need to be avoided. Dignity and respect. Now, examination tables and delivery beds should be separated with screens. This is absolutely a doable thing in public healthcare settings as well. Expose only the appropriate body part during the examination. And then once you've done the examination, to cover the patient back. So these are small things, but it is, they get missed out. The reason may be because we are not trained to take care of these things. These softer skills are not told to us. It is not a part of our curriculum. Although now with the EdCom model coming in, I'm to say we do have emphasis being laid to it, but in our day-to-day teaching programs, in our day-to-day practice, these things do get diluted somewhere. Then explain and take consent before any examination, especially when we do a PV examination in labor. Then share the findings of an examination with the woman and a family, right? And then listen to the woman carefully. And whenever a woman calls during labor, it is important that the nurse and the doctor should at least listen to her so that, she feels that she's being heard and there are people who are going to take care of her. Equality, freedom from discrimination and equitable care. Now, we all know that, depending upon the patient's caste, religion, socioeconomic status, how educated she is, which strata of society does she come from, is she a VIP, she's not a VIP, and then her HIV status, etc. A lot of discrimination does happen. So I think it is important that we ensure that all the mothers, irrespective of caste, creed, anything, the care should be equitable. Timely healthcare and highest attainable level of health. It is important that whichever place we are, depending upon the load at that facility, we should be able to organize our work in such a manner. I'm sure Aparna will take you through the point of care quality improvement methodology. There are methods available. It is just that we have to empower our healthcare providers to identify their problems and then solve them one by one. So nothing is impossible. So, but the only thing is we have to identify, list out our problems, prioritize them, and then fix them one by one. So if a labor room is busy, it's important that we organize the labor room and related areas in a manner that enables prompt, complete, and quality care for every mother and newborn. Say, we can have our inductions on one side, we can have, primary patients on one side who need more care. And, so that kind of organization should be there. We should not leave the mother unattended. We should ensure that every mother and newborn receives full package of services at the right time in a correct manner. So the skin-to-skin contact, early initiation of breastfeeding, all these things must be done. The fact of the matter is that, in the private sector specifically, the baby is taken away from the mother and the baby is kept in the nursery for observation for 24 hours or 48 hours. That is undesirable. We are depriving the mother of whatever healthcare she should be receiving. So these are evidence-based practices and they need to be followed. ensure recommended practices for infection prevention for every client. This is very, very important. The last is liberty, autonomy, and freedom from coercion. So liberty of decision-making. We say that the patient is she's asking for a cesarean, right? And we do more cesareans now because our patients are asking for it. But after all, it is important. Why would the patient ask for cesarean? We need to talk to her. We need to, apprise her for the benefits and, disadvantages. And then it should be an informed decision-making. Inductions of labor. We just decide on induction of labor. We do not give any other options or any alternatives to our patients, especially for induction past date. The moment she crosses her EDD, we don't give her that option of whether, she can continue for another week and wait for the spontaneous onset of labor. So it is somehow, we most often dictate things, and it is not a decision making. It may be because of avoiding medical legal, litigations or whatever, but we do deviate from what is evidence based. Then the patients may be discharged early if they're not willing to stay after explaining the consequences. In government hospitals, we often see that the patients are wanting to go home, and because they are sick, we want to keep them in the hospital. And we feel that if they go home, they will not be taken care of, but then they go LAMA. So that is left against medical advice. Then when they go LAMA, they do not even have a slip. So that means a patient whom we were not discharging, because we were worried she would not be taken care of at home. She goes home without any treatment and without that option of coming back also open. So it is important that, I remember a story when there was a patient who was wanting to go home and no one was allowing her to go home. So I asked her, I said, what is the problem? Why don't you stay back? She said, I have 2 little daughters who are alone with my neighbors. So there's every reason this lady wants to go home. So I think it's important that we should do discharges on request and allow the patient and listen to the patient and help them with whatever we can. So respectful maternity care is the right of all pregnant women. It is the predictor of health-seeking behavior of our future generations. It should be in the DNA of all the health systems and can be provided without any additional resources. It is sad that we are discussing this here at this forum, but believe me, it is not a problem only which is, India-centric. It is global. It is global. The disrespect and the harm or the negative experience which a woman get may be different in different places, but it is there in some form or the other. Remember, maternal and newborn care, if looked through the prism of quality, has to be safe, has to be timely, has to be equitable, has to be effective, has to be efficient, and has to be patient-centric. So nobody can go back and start a new beginning, but anyone can start today and make it a new ending. So with this, I would end my talk and hope that we take forward this movement of making childbirth or a pregnancy a positive experience for all our mothers. Thank you so much for patient hearing.
Thank you so much, Dr. Manju. Over to you, Aparna. We'll take the questions and discussions at the end. Is that all right?
Yes, ma'am. So I'll just start. So a very good evening to all of you. And I'm really thankful for the team of Marvelous Medicine for having us here. And I must thank Tilaka. She's a very good friend and she's the one who introduced us here. So what ma'am has said so far is very vital, and we are both very passionate about this journey. And I would talk a bit about what we have done so far. This is just the beginning where we have started. And I would like to talk about why we started. Ma'am has given an overview and, and what is the path that we have taken. It is easy to say that, it is something that needs to be done. I think this is like something that really doesn't actually need to be said. But what is important is how do we plan to go about it, what we are doing, what we have done. and what is the the content that we're talking about, and what are the next steps to it. So these are the various aspects that I would be covering. But before that, just to build up the adrenaline a bit, I would just share a video which was featured by the Time magazine, which actually gives and states the hard facts. So I will just take 2 minutes of the time to share some of the facts here. So like ma'am said, it is not just an India problem, it is across countries, across continents that this problem exists. And the main problem is that it is so difficult to measure the mistreatment about what is happening. This has been existing for decades, but how do we measure respect? How do we measure RMC? And improvement, if we want to say it is improvement, we need to understand and try and objectivize it. So just going through this paper, which talks about mistreatment measures. So verbal abuse, use of harsh language, failure to meet professional standards, lack of informed consent, physical examinations and procedures, lack of privacy, no partition between beds, conducted examinations without information or privacy, and provider did not cover the mother during examination. So breaking down the concept of disrespect and abuse into first order, second order, and third order themes in order to understand how we can actually go into the depth of the problem and try and elicit what needs to be improved is something that we are actually going down into it. Also, there are aspects to clinical quality, that is creating rapport. So essentially basic things like welcoming in a gentle manner, calling the client by name. A very basic thing like calling a lady by her name is rare. And telling her where to go, where to wait, that is something that also needs to be looked into. Basic practices of taking medical history, physical assessment, of course, that also needs to be assessed. So when we actually tried to understand all of these things, so this paper actually said that the prevalence of all these problems was to an extent of 50 to 80%, somewhere ranging to even to that extent up to between 50 to 70%. So we know the prevalence of mistreatment is huge, but to objectivize it and try and understand what is the prevalence in all aspects across various facilities was something that we are looking into to try and change and where to intervene. So with this background, we started a movement and we named it the Sarthak Initiative. Sarthak is sensitive, attentive, respectful, timely, and humanized care. So and it is also to be believed that when a child is actually born, the mother is also born. So let mothers be born with safely and with respect. So to begin with, the respectful maternity care bundle has to be launched. And this is a movement that needs to be, really pushed, and it has to go on full steam ahead. So, in this particular initiative, we brought together the AOGD. AOGD is the Association of Obstetricians and Gynecologists of Delhi. It's a huge body of all of the obstetricians who are practicing in Delhi, WHO India Country Office, and the QI Committee of AOGD. QI is the Quality Improvement Committee, which was initially started by Dr. Manju Puri ma'am 2 years back, and now we are together in this committee. And we thought of taking this aspect forward. And now Madam is also leading the NARCHI, which is the National Association of Reproductive and Child Health of India, and she's the president. And under NARCHI, the rest of the initiatives are being taken forward. So after coming together, we decided that there is a huge need to take this aspect forward. And as a first step, we started this program and to create the learning resources and toolkit for training the professionals, and to develop the catalysts of change, the master trainers for this Sarthak toolkit, and to provide a platform for dissemination of this toolkit. And once we have had these master trainers and we have disseminated this, we need to build advocacy for incorporation of this version, or an abridged version or a modified version, into the undergraduate and the postgraduate curriculum. Because unless we train the future doctors, the concept of respect cannot be sustained. So this has to be trained right from the beginning. And this is the idea that we need to build an advocacy brief on the pilot implementation for scale up for the pre-service and in-service education. So with this concept in mind, we have started this movement to across Delhi for now. And in the first step, we have done the training of trainers meeting, which was done on the 6th of December of this year, where we included 9 institutions across Delhi, which included medical colleges, which included district hospitals, and also, so this particular, the TOT, which was done in Maulana Azad Medical College, it included medical colleges and various other hospitals. And interestingly, this was actually an amalgamation of people from the medical colleges who were professors, who were teachers, but also in service nursing leaders who were already working in labor rooms, and they were also nursing tutors from the nursing colleges. So we had a very good and interesting discussion. And following this, there was another meeting within the next week, where like I mentioned, NARCHI is an association which is currently being headed by Manju Puri madam, and in which the Delhi government has taken up this initiative very soon after. So the maternal health division of the Delhi government has taken up this initiative to spread this movement into the district hospitals of Delhi, where 11 facilities from the Delhi government attended this orientation workshop and understood this concept, and has committed to a cascade training within each of their facilities. So currently we are at a level where we have commitment from at least 10 to 15 facilities for taking this up within the city of Delhi to do this workshop in their own facilities. So this was the 6th to 7th December workshop. Now the component of workshop, what are we training? Now respect is such a fluid term. What are we trying to tell them? So the first concept is to tell them birth needs. And it is such an interesting concept that, when a mother comes to a facility, she has certain expectations that, okay, there is certain expectation from the facility, certain expectations from the provider. While the provider who's providing the birth facility to the mother is actually, in a very clinically providing care. Now, what are the expectations match or mismatch between the the person who's providing care and the person who's expecting care? So that is the first activity that is done in this workshop, to understand the mismatch or the match that is there. And there is a huge component of the communication. And whether we agree or not, somewhere as doctors, we miss out on communication. There is no formal training on communication methods, while communication is one of the most important aspect whether it is emergency, whether it is routine care, while obstetrics is such an emergency based, during labor room, intrapartum care. So there is a huge session on communication. And the third aspect is simulation. Now, people will think, why simulation? Simulation is for obstetric emergencies. How are we teaching respect through simulation? But it is so important, because respect is the first thing that goes out of the window in an emergency situation is respect. So unless we hardwire respect into our system, that even in under very, very strenuous situation, we have to be respectful, this is not going to happen. So there are scenarios where we talk about respectful maternity care during labor, during PPH, during shoulder dystocia. We have to be hardwired and talk and behave in a certain manner. And that is what. So this was an initiative with a difference. We had 2 full days, 2 half days of a virtual workshop, 2 full days of a physical workshop, where we talked about respect, for the full days in various manner. So that is something that was a huge, I think, initiative. And we really feel that, we talked about it in all forms. So messages like this, I know this is a South Indian audience and may really not connect with so much of Hindi which is being written here, but simple things like, the concept like हमारे यहाँ जन्म देना एक महिला के लिए बहुत आनंदमय अनुभव होना चाहिए. It should be a happy occasion, not that it should be a fearful experience. So messages like this, they cut across populations and they reach out to the people. And when you write it somewhere, subconsciously, it goes into the healthcare providers, it goes across to the patients and the healthcare providers. And we talked about the various communication techniques that are very important across the normal situations, across emergencies. So following the first workshop, we had another workshops in Lady Hardinge Medical Colleges where all the Delhi government facilities, 11 Delhi government facilities came in, and they were so enthusiastic about the concept of respect, and they agreed that this is something that needs to be done. And all of them have committed to doing this in their own workshop. And the first one is being done in Maulana Azad Medical College itself on the 30th of this month, where they're going to talk about RMC with their own residents and the nursing staff of the labor room. So till the time that it goes down and percolates in each and every medical colleges, that is the end point where we think it is going to be there. Now, a very basic question, I think, will be in each and everybody's mind. And I think that is where we started, is that what are we trying to accomplish? And all of you who have done quality improvement or are aware of this IHI's model, Donna-Obedience model, would say that how will we know that this is an improvement? What are we doing? And this is where the quality improvement principles come in. And me and ma'am, we have been working together in quality improvement for the last 5 years, and we've done various projects, worked together on collaborative projects. And so whatever we do, we try to quantify. We try to understand that whatever we are doing, is it going to change? Is it actually an improvement? So unless we objectivize this, talking about respect is not the end. It's nice to talk about it, being very emotional about it, but till the time that we prove it, it doesn't go anywhere. So from the paper of the mistreatment that we talked about, we decided that, we can kind of objectivize it by taking 10 parameters, which are very, very clearly seen or documented. Now, this is a proposal that we can do in our setup. It is not watertight. People can take up what they want to do, but planning a quality improvement project on RMC. Now, this is point of care quality improvement model that we have developed along with WHO India, All India Institute of Medical Sciences, Neonatology and Gynae department together. This has been for more than 8 years now. We've done n number of projects, lots have been published, lots work done. This model really talks about 4 steps in QI, where you talk about identifying a problem, forming a team, writing an aim statement, analyzing the problem, developing and testing changes, and sustaining the improvement. Now, putting RMC into QI is something that is going to tell us that, okay, what are we doing? Is it going to help? Is it helping? Do we need to change? So these are some of the QI methods, utilizing QI methods, some of the publications, just to say that, this is something that we have experimented with. We have been working on quality improvement methodology for the last so many years, and we believe firmly that this is the way forward, even when we are trying to implement RMC. So we have taken this 10-point objective scale for scoring a RMC in any setup like our labor room or any labor room. So if you've made a 10-point scoring system, we have to identify a problem that inculcate the practice of RMC during labor. And during, who are the team members? We will include the LR residents, our staff nurses, nurse in charge, faculty in charge of the labor room, and sanitary staff, because those are the people who are interacting with that. And what is my aim statement? It is to encourage the practice of RMC during childbirth by objectively improving the parameters of rapport, disrespect, and abuse from the current level by at least 50% over the next 6 months or the next 3 months. So that is something objectively that I have made my aim statement to work on in my setup. Now, this template gives us whether your aim statement is good, do you need extra resources, why is it important to do this quality improvement, and do you think your team is right? Do you have influential people? Do I need to have my head of the department on the team, because maybe I need to need the support of my head of the department? And how do I measure it? How do I measure it? So now suppose I say, one option is I can measure an individual attribute, like the number of women in whom the healthcare provider explained the procedure, like doing a PV examination before performing it, divided by the number of women who were observed. So that is one individual parameter for observing it. The second option would be that you score it out of 10, because I have decided 10 parameters. So I allot one team member to score on duty days, observe 1 or 2 interactions on a duty shift, score out of 10 on the scorecard, which could be charted as a percentage, and a weekly percentage calculated to reflect on the time series chart. Now, this is a plan where I can objectively score my progress. So this is how we plan, like, the quality improvement data can be planned. Allot a percentage, a person to collect the data, allot the data sources, and maybe collect the data of weekly data. And now the most important is, what is your change idea? What will bring about the change in your system? To begin with, one RMC orientation workshop and posters on RMC, because I need to orient communication. I need to tell them that, okay, this is your basic thing. It is really unfortunate that somewhere along the line, I have to teach respect. We have to talk and teach respect. But if we have to do this. But yes, the first change idea is orientation and RMC workshop. But do we think that this is enough? Maybe not, but I'll try it out later. But the first thing that I'm going to do is do a workshop in my setting and see how it works. And this is my last slide that I'm going to talk about. This is an idea whose time has come. RMC is the way forward. The Lancet paper says that beyond too little, too late, too much, or too soon, we need to talk about respectful maternity care worldwide. There is no other way to it. If we do not provide respect, people will not come to our systems, however good we are. People will not access care. So respect is something that we need to inculcate in our healthcare providers, in the future generation of healthcare providers. WHO recommendations talk about intrapartum care for a positive childbirth experience. And this Christmas 2022 article from BMJ talks about respect. So careful, kind care is our compass out of the pandemic fog. Whether you call it the pandemic effect, or whether you call it the generational effect, there is a lack of compassion. There is a lack of respect. And this is what we are fighting for. And we do hope that in this journey, we will find it somewhere. So thank you very much. And this is what we wanted to share. Thank you.
Thank you, Dr. Puri and Aparna. Dr. Puri, would you want to add anything to what Aparna said, since your talk was more introductory?
Yeah. So basically, I think I agree with all what Aparna said. And we feel that there has to be a lot of advocacy as far as this particular aspect of care of mothers is concerned. And this is the way forward which we feel. Because everyone would say the places are very busy. and people are very stressed, and that is why they behave like this. They do not have time. But then I think it is time that we understand that it is not about the availability of time or places being busy. It is more about your own attitude, your behavior, and your communication skills. So that is something which is missing, and that is something which has to be brought in our practices. So that is all what I would want to add.
Now, over to you, Minnie.
Thank you for this, beautiful exponential talks, actually saying that you're bringing about extensive changes in the way maternity care is being practiced. I work in Abu Dhabi, and the setup is slightly different from India, actually. But in my hospital, which is SSMC Mayo, we believe that patient care comes first. And since I work, I have been given the project to do the low risk ambulatory care, where I am looking at now what is essentially being dehumanized. That is, maternity care has become, removed from the fact that it is physiological process, something that is normal for most women, something that should be enjoyed. And, we are following a tick box. These women come, first trimester, these things have to be done. We forget to talk. Now, what you are already aiming at, we have already started practicing in many ways. We also have classes for respect now. We really have classes, for instance, we should not use certain gestures for the patient. Like, for example, like this, you say, please wait, we cannot lift. We are not supposed to lift because this is humiliating to the patient by putting her down. We are not treating her as an equal. This is one. The other thing we practice is midwifery care. So this is where, you're already doing it wonderfully by, it is for you, it's a step down, like you're teaching everybody else that this has to be done, what we were taught before. And what we really need to teach others is that every patient, as you said, requires to have their own safe space, and treat them as a triad, like, the mother, the baby, and the family to be treated together as one. And how much of midwifery is being practiced now? Because about 80% of our deliveries is by midwifery. The patients we are not successful actually because of staffing problems, but we attempt to give one-on-one care. And this has led to a lot of, comfort and safety net for the patients. So Dr. Manju and Dr. Aparna, I'd like to have.
So, we are also trying to have midwifery system coming in place, and the government is kind of pushing it, pushing it now, because in 2018, they came up with the guidelines, and now midwives are being trained. There are a few initiatives which have been made in Telangana, and they have the first set of midwives who are ready. And I think that is definitely a way forward. Because that would be a 1:1 initiative. Now, what I personally feel is when we talk about obstetrics and gynecology, we fail to understand that there are two specialties, separate specialties. So somewhere the working hands are not adequate to look after the mothers and to give them care which actually is required. So it is the obstetricians themselves also who are under a lot of stress, and the mothers are also under stress. So there is a mismatch between the care providers and the clients whom we have to look after. So I think midwives, if they are added as a new cadre, it would be providing additional hands. It would take the load off the obstetricians to some extent, as far as the low risk mothers are concerned. And it is a different concept altogether. So, when the midwives deliver birth babies, it is more of a natural birth. All those natural things which have gone off the track will come as a new package. That is what we are, expecting. And that is why the midwives, I always feel that the midwives have to be trained differently. They cannot be the normal nurses. They have to be out of the circulation. They have to be standalone nurse midwifery practitioners, midwives, whatever we call them. So I think that concept has to come in. So we have to normalize childbirth. I think that is where we
Yes, exactly. Yeah.
So we have Dr. Santa Singh, who's the director of RIMS. Santa, you have your hand up. We'd like to hear from you. An obstetrics and gynecologist himself. Santa, could you just unmute yourself? Okay, we'll come back to
yeah.
him. Yeah, there
Yeah.
you go. Yeah.
No, it was a very nice talk. And after a long time, I'm seeing the mini Ravi. So I'm very, very happy. And I was a co-examiner with Anju, Madam Anju. So it was very nice. And to see you, very nice. And new concept is very good one. Thank you.
Mini, do you want to address any of the questions in the chat box or comments?
1 minute.
So till you go through them, Ghosh, you've been logged in right from the beginning and typing away comments. We'd like to hear from you. Meanwhile, Mini, can you just prioritize the questions in the chat box?
Thank you. Thank you, Vidya. This is excellent talk, much needed. But in my experience going to the OBGYN in Jipmer and subsequently in Chandigarh, where my wife was a resident, I would frequently visit her. There are different, women are very hard sometimes on women, saying that this is a normal procedure. I have gone through it, so why should you create such a dilemma? So men aside, women themselves are very cruel, often on women. Having said that, even in Jipmer and other places, I saw exceptional care even before this talk was there, taking all the highlights of these programs. And I'm sure Dr. Manju and Dr. Aparna had this way before they created this. So there are women who are hardwired for these kind of behaviors of careful, compassionate care. But it is not uniform because the mentors are different, because of the pressure of the public hospitals, it is different. So the way these things have been laid out, whenever we have human beings trying to control uh, an environment where there is so much interaction, all kinds of corrupt behavior comes. So we cannot rely on the goodness of an individual human being, however good they are, to carry on these behaviors and expected practice. So what has to be done is legislation, laying down all the expected care and expected behavior and actually whip it into action. So there is not going to, there's kindness and compassion so much for people who are already outstanding. They don't need this. But there are people who have no idea, but they can be modified. They can be changed by these outcomes. We have seen in Mayo Clinic that each of the behaviors have to be asked for. So it's not like you are the highest qualified OBGYN or something that you will get an admission in AIMS. No. I know Dr. Randeep Guleria, who was my senior in Chandigarh, how careful, compassionate person he is. And he was my senior at that time. I was so glad to see him end up as director of AIMS. So it stands to the leaders to do this, but it is not only talk. In Marvelous Medicine, we have talks on communication and all these aspects which have been talked about, SBAR and all that have been discussed. But is it being implemented in the thousands and thousands of hospitals in India? Probably not. But this is a great movement in Delhi. Unfortunately, all the great things happens in Delhi and stays there. The percolation from Delhi downward is a very slow process. So what my request to Dr. Manju Puri and Dr. Aparna is make as much noise as you can. It is such an important thing, make it. You'll have a lot of pressures, both political, internal, but this is something to stand for women because it's such a regular process is thought to be, what is regular is thought to be like something to be dealt with, doesn't matter what kind of behavior you met out, but each woman is important and each behavior is important. At Mayo, I was one of the 5 members to attend a conference called GRIT. This is all women conference where they talk about all the behaviors of women who keep apologizing for all their things. They keep saying, I'm sorry, I had to do this, I have a family problem, I came late. And they have asked women to stop doing that, stop apologizing. Men do not apologize. If I come late, I come late. Like, you go suck it up. So things like that, is so, I'm going to this conference called Apicon and my wife, who's also a Lady Harding graduate, is going there. There are only few women speakers other than OBGYN, where there are women speakers. Rest of the medicine, maybe opthal, there's a lot more dermatology. There is no percolation. So this is not happening in the surgical specialties as much as we want, or the medical specialties. These are behaviors of respect. In the hospital, it has to be everywhere. So you can have this massive thing in OBGYN, but if the residents don't see it in surgery, don't see in orthopedics. In orthopedics, I was told there are 3 kinds of anesthesia, 3 or 4: vocal, local, vocal, and tocal, which means just give it to them, right and left. So these were the kind of trainings that I have come through, and they are so inappropriate. You laugh at it, but it's so inappropriate. So I'm glad that this is happening. But I tell you, you have to be so mindful, even within Mayo Clinic and the best institution in the world. We have what is called whisperers. We have people, we have empowered our nurses, our front desk people to look out for bad behavior from doctors, to look out and report them. There is all kinds of reporting system which happens, and the action needs to be taken against the doctors, whoever he is or she is. And I have to retract this. The biggest problem for women, especially delivering, is women themselves, the midwives and doctors. So as much as you're trying to preach to the rest, you have to look within your own department and see. You have gone through residency yourself. You realize who these players are, and they're completely oblivious of it. There's a blind side. Like in SSMC, which is a sister institution of Mayo, you'll be fired right up. There is no way. You'll be fired. And if there's no consequence of bad behavior in Ames or Lady Harding or anywhere, you have a government employee, you're hired for life. Nobody bothers about it because you're a VIP, is your father or mother or husband. Your patients will suffer regardless of whatever PDSA you do, whatever. We are people bound to be corrupted. As human beings, I'm sorry to say that until unless you legislate, put it through, codify it, expected behavior, we will completely detract from the norm. And that is the norm everywhere. So regardless of what paper comes out in BMJ and others, the leaders have to take action. And I think I really compliment for what you're doing. And I've learned a lot. I took a lot of, I keep writing these things. So thank you for your amazing, amazing talk, but you have a hard task. You're talking about 1.3 billion people and trying to work there. It's not easy. Whatever works in SSMC and Mayo will not work in your place. So you have to use the techniques you have and implement it using, going to the highest level of leadership and implementing it. So the director has to hear, all the other chairs have to hear, and the curriculum has to be heard, has to hear to what you have to say. So make a lot of noise, and educate the patients. This is Bill of Rights. We have to hold doctors accountable and nurses accountable for bad behavior. Otherwise, it's going to happen. Sorry, I took a lot more time, but it's a very passionate thing for me. And I was so happy to see that you're making a lot of noise, you're putting signs, but you have to go beyond publications. I mean, you'll get very famous advocating it, but it has to be, to change a system, you have to imbibe those habits. And just having a system, a procedure in place is not enough for change. So like Dr. Ravi said that, Mini Ravi said that in Mayo, we have what is called the need of the patient comes first. You have to feel the need of the patient. There is no way other than that you can change or transform care. But it has to start from you, and you have already started it. It's amazing, amazing talk. Thank you very much.
Dr. Ilango, you had your hand up. You wanted to say something?
I fully agree with Professor Ghosh. One of the gynecology and obstetrics was one of the most hated subjects when I was an MBBS student. The simple reason was that I had a memory of women being slapped on the thighs during the time of labor, and it left a very bad taste in me as a medical student. So I just scraped through, and only recently during my during this COVID time, I started teaching people a lot of obstetrics when they were returning from CAS countries, MBBS training. And that's what got me interested. So recently I've got all the stuff that is required for obstetrics and gynecology. And this is very interesting. Your talk is very interesting. There is another thing which I believe that obstetrics also has to correct, is the way they treat their own junior colleagues. I think the toxic work environment is another factor which is indirectly reflected onto the patients. It's very difficult to avoid even in a private hospital, especially when there are residents and junior medical officers in training. So these are my thoughts. Thank you. It was a wonderful talk. It's a wonderful initiative.
Over to you, Minnie.
Yeah, I respectfully disagree, Dr. Elango. This toxicity is across all disciplines, not only across OB-GYN. Yes, we do face it. And by using this respectful maternity care to start, as a base, I think we are not going to be practicing toxicity further. But this is something that pervades across most of the medical specialties, not only OB-GYN. Maybe it's more evident there because you have a lot of deliveries. And I honestly, feel very much being an Indian woman, that, we deserve the respect. We need to be treated well by our physicians, whether it be an obstetrician or any other specialty. But in obstetrics, the woman is at her most vulnerable. In Tamil, we call it Maru Janmam, just as Dr. Manju and Aparna said, rebirth. The woman is at her most vulnerable and she can do nothing about it while she's giving birth. She needs to be treated absolutely. The other thing, Dr. Manju, I had a question is, what about anesthesia, epidural? Do you practice that as much as possible? Because I think that by empowering women to receive obstetric analgesia, that's one of the deepest form of respect we can give her.
So, Dr. Mini, can I take this? So basically, in our institute, what we have is the concept of birth planning, where we invite every woman who's between around 32, 34 weeks, and we offer them the option of analgesia, and we counsel them, what happens when they go through labor, birth companion, analgesia, mode of delivery, and contraception. So, those concepts are covered. And we offer analgesia to everybody, and the uptake is around 40 to 50%. So we are offering it to all. It may not be available across institutions, but so wherever it is available, medical colleges, they are, and private, of course, it's available. But in public facilities, a lot of medical colleges do offer, yeah.
But Dr. Aparna, you're saying even when offered, 1 in 2 women decide not to take
yes.
Option of analgesia. Okay.
Yes.
And can I just comment?
Yes.
But when we talk about labor analgesia, I fully agree that this is one of the neglected aspects, and just by focusing on it also would add on as far as the respectful maternity care is concerned. But small things like allowing them to move around and having someone to give them massage, back massage, and when we look at midwifery-led care, there not many women would actually require analgesia. It is more because there's so much of stress and anxiety that leads on to so much of catecholamines that the pain threshold per se goes low. A well-prepared woman may take labor pains more positively. So especially in Fernandez Hospital, they have tried, and ever since the midwives have come in, they said their uptake of epidural has gone down tremendously. So it is not that epidural should be available for all. So especially in heavy load facilities where you have less of anesthetist, there are so many other things which one can do to minimize the pain. So, because epidural is not available, people don't do anything. So they don't even give them the normal analgesics. So it is all an unlaw. So I guess that we should try and comfort them in whatever possible way it is. And definitely we need to look at the pain management of you.
I have one more thing to raise. I read a very interesting article about a time out because many women complain about this traumatic experience in the second stage of labor. So there was one article, I think a Swedish article, which talked about giving a small time out, like, at that moment of time, you're able to discuss with a woman and tell her how this is going to go through. And this is another way you show respect to the woman and, enhance her childbirth, her enjoyment of childbirth.
Yeah, it could also be an important safety point, right? Where because if you have a, say like how they're telling in a government institution where we don't have a separate room for everybody, there is this huge labor room with so many cots and all that, and identity issues and patients not being called by their name. So this timeout would not only help to prepare the woman, it would also make sure there is no mistakes made as to patient identity and other things. Yeah. So Dr. Radha Pandian, a senior obstetrician, is also logged in. She's been typing all her comments. Madam, we'd like to hear from you straight.
It's been so wonderful. I congratulate everybody, Madam Manju Puri and Aparna and Dr. Mini Ravi, Dr. Amit Ghosh. It's been fantastic. And I feel it's absolutely the necessary thing. What you're doing is so fantastic because the government is loaded with so many patients and who are just left for their own fate and in labor rooms. In fact, I have worked in government hospital Egmore and the government hospital in Brunei and a private hospital in Apollo. I can see the difference. I could perceive the thing, how we have taken our private patients in a small batch versus a big load of government patients. And in fact, one of the things which made me resign from government service was the absolute plight, as somebody commented here, the plight, patients lying on stainless steel board, cold boards without any cover, and patients shouting away in the last room and uncared for. Certain things are just traumatic in our memory. So I agree. Whatever initiative you have taken is fantastic. And I really salute the people who have taken the initiative. And I wish, as Dr. Amit commented, it goes across the country and helps the millions of people. Thank you so much. And I wish you good luck for your journey forward.
Dr. Venkatesh, you have your hand up. Can we hear from you?
Yes, ma'am. Yes, ma'am. The question is, for giving a very personalized care in a country like ours, especially as what Radha Madam was suggesting, memories about occurring and other purposes, just like a war fight one another considerably from that kind of situation about 20-25 years ago. Now the question is, in educating the team, deliveries could be reasonably conducted. For example, is it possible to run 5 deliveries simultaneously with 5 different teams? Is that possible even in our country, where it is possible to give personalized attention, where the team is very calm, composed, understand the nuances of when they cross the line, when rudeness takes over, I mean, the situation, becomes very tense and all that. But generally, the common refrain is people misbehave because it's very stressful, which probably should not be accepted as accepted. So my question is, how many members should be in a team in order to safely execute this?
Aparna, would you like to take that question?
Ma'am, actually, I think I don't know if it was my network or I couldn't get the question very clearly, but I think it was talking about heavy caseload facilities and,
He just wanted to know, whether in India it's even possible to make sure there is a one-on-one, like whether it's a midwife or whatever, one caregiver for each birthing lady. That was the first point. And whether at all it is, have you seen a place where whatever you were discussing was actually happening? Have I got it right, Dr. Venkatesh?
Yes, ma'am. Yes.
Yeah.
So, ma'am, actually, see, the point is that, like we said, it is actually a perception that we are misbehaving because we are stressed. because we try and justify our misbehavior because of so much overwork and stressed, because it has become such a habit that we misbehave even when we are not stressed. So what we are talking about here is hardwiring of a behavior which has already happened. So essentially what we talk about here is, and if you talk about the systems, if it is already existing, an ideal system, I cannot claim that an ideal system is existing. It cannot exist at this point in time. But what we are seeking is that if there is a system which is majorly functioning without any major showdowns, that is what we are looking at, where there is no mistreatment or abuse majority of the times. And that is what we are targeting here, because the people are trained not to shout at people, not to shout at patients. And this is what we are looking at. One-on-one care in a public healthcare facility may not be possible, but it is possible to treat women with respect, to address them. Simple things like address them with name, tell them before examining that, look, I am going to do an internal examination for you, provide a cover, curtain them, provide a curtain, and provide audio and visual privacy. These are certain very basic things which will go a long way in improving care and providing the respect that we are talking about. And have an environment. Like when we go into the labor room, we say to the labor room team that, look, this is your area of work. There should not be any shouting. There is no disrespect in the area that you are handling, and that where you are having, where in this area of work. So this is exactly what we are looking for in a public setup where we might not. And I would also like to say one more thing here. I can see the comments. There are people who say that I hate Obs Gynae. I have had developed a hatred for Obs Gynae from the behavior that, maybe they had so many years back. We all understand, we all have gone through the thing. And this is where we want to, really trying to change the system here. Everybody has gone through somewhere that kind of a system, but we are trying to change here. And there's a huge movement from the government itself since 2016 onwards, when the Lakshya Labor Room Quality Improvement Project was launched, where it is a mandate from the government to have a birth companion. And birth companion has been proven across the globe to be a single most effective initiative to decrease abuse and disrespect in labor. So if you have a birth companion, so even if it's a busy health case load facility, there is a stool or a chair next to the patient where a birth companion is supposed to sit across healthcare facilities in India. And this is a mandate, and like Dr. Ghosh said, you need to have a legislation. So this is actually a requirement from the government that you need to have a birth companion. It may not be the husband, because it's not possible when you have, but you can have a female. So, there is a movement, there's a huge movement. So we have moved on from where we were 20 years back, and all of us were undergoing our MBBS. So we are trying to move towards a positive environment, and there is a huge push right from the top. And what we are trying is bottoms up approach, where there is a push from the top, but really it has to come also from the down. So we think that it's possible, but yes, like Dr. Ghosh said, we need to make a lot of noise that yes, it's possible and we should do it. So small measures, small in whatever way it is possible. We cannot, really change the infrastructure. We cannot provide, single cubicles, but we can do what we can do by changing the behavior of one-on-one behavior when a person is talking to that lady. That is what we are looking at.
So Aparna, if I can just jump a little ahead, before you rolled out, in the official way and collaborated with the Delhi government, and I'm sure you did your own pilot or you must have been doing this for a while. This, trying to propagate respectful maternal care. So what was your approximate timeline for you to see some change when you, like the 10 points, you said you wanted quantifiable points and simple to, not very complicated, simple things that can be done also easily and can be confirmed also easily. So you chose those 10 things. Was the woman greeted when she arrived and things like that. So what was the approximate timeline for you to perceive change? And did you, the change was from data that you collected, or from the patients, or feedback that you collected from the moms, or was it observed by some other healthcare professional?
So, ma'am, exactly. So, essentially, so when we this thing we started even before the COVID pandemic, when we had developed a checklist for communication, whether all of these things are being done in the labor room, to what extent are these being followed. So that is where it all started. And like a quality improvement project, we took it up, and we generally have a timeline of 2 to 3 months where we talk about the change to come in a certain population, in the certain residents who are posted in the labor room. However, the sustainability is seen over a period of 6 months to 1 year. That is what we are looking at. After that, we've actually, through the Lakshya initiative of the government of India, we've gone to various medical colleges across country, and there also we've taken up certain QI projects on communication, not in terms of exactly calling it RMC and including all of these components, but we have done this project as effective communication during labor and in labor rooms across various medical colleges in the country. And we have seen that it is feasible to be done, but the sustainability, of course, will have to be seen over a period of time.
My question was about your own unit or your own area, how long did it take for the change to actually be seen? That was my question.
So like I said, ma'am, everything like 2 months to 3 months is the initiation time. And then, of course, the sustainability. So we initially put the changes. So first is the orientation program, then we have the posters, and then we start taking the measurements every week. So we have every week, and then we see, so it's generally 2 to 3 months, and then we collect data for over 6 months to 1 year.
Right. So Dr. Manju, you wanted to say something?
Yeah, Dr. Vidya, actually, as far as this particular set of 10 points is concerned, this is what we have proposed, and we are ongoing. We are just, in our hospital, we will have a first workshop and move on. But things like birth companion, it was so much of resistance. We have about, 60 to 70 deliveries happening every day. So the labor rooms are full. So there was so much of resistance from everyone. No, they are going to obstruct our working, and the nurses were not happy, the doctors were not happy. But now we have. So initial rollout for any QI project, when we think of one intervention, would be a period of about 3 months or so. So anything between 6 weeks to 3 months. But then, as Aparna said, we now have birth attendants, companions with our patients. The patients feel, less scared. They are more comforted. And, the people, the verbal abuse also goes down, because it is not the vulnerable patients alone. It is the relatives who are observing. So everyone is under that radar. So naturally it has gone down. But, we have to think of small interventions, and whatever is possible, we first take that, which will give us more results and will take less effort. And then we move on to the more complex ones. So I think now we are moving on to more complex ones, which would mean that, the communication, the way they talk to the patient, and what are the contents of that, thing, talking to the patient by name, taking permission. So, they would be gentler in their approach, but they would not take consent. They just put the patient, they would not tell the patient the findings of PV examination, but they would not, pull the legs apart, or would not be rough in front of the relatives. So I think that is how the changes are kind of happening, and that is the beginning. And as Aparna says, the government is now on board. They want it to be rolled out. They are talking about it. I think once we start talking about it, people who were actually taking it as a norm, their right to be talking and behaving in whatever manner, now they know that they are being observed. And of course, for it to be effective, I agree with Dr. Amit when he says that there has to be legislation. Someone has to be, a neutral person has to be observing and telling this is not correct. So I think that is the way forward. Yeah.
So after speaking of something serious, I don't mean to be flippant, but this doubt, I have been working in the private sector for a long time now. So when we talk about patients' rights and all, is having a cesarean birth patient's right when there is no indication?
Yeah.
I mean, if the obstetrician refuses to do a cesarean where there is no indication for cesarean, would that be disrespecting the woman, or where do we stand on that?
No, there a detailed consent and an honest consent is important. What happens is that it is only the advantageous part which is kind of told, and the complications. Say if we explain them that you can have, the risk of anesthesia is more, or maybe you can have adhesions, you can have sepsis, you can have long-term problems in the baby. The baby is more likely to have more autoimmune disorders because the baby is not exposed to the biome. So I think all those things, if we talk about, then it is fine. If it is an informed decision, then of course you can go ahead if you feel it is okay. But somewhere the obstetricians also given, I would say it is more to do with their practice and other things that, it is more convenient for them. I feel it is something like female feticide. Both the obstetricians and the ultrasonologist and the patient were on board because all wanted that. We all said we are doing because the patient is wanting it. We are seeing the number of complications of cesarean section which are coming. And say if we show them those pictures of cesarean scar pregnancy and morbidly adherent placenta, we don't dissuade them. We agree to what they say. We are also kind of gullible. That is what is my feeling. That we do not stay put. We feel it is okay. So it's an easy way out for us also. That is what is my feeling. Aparna can come in, and give her.
Minnie has her hand up. Minnie.
Yeah. So there was about 2 years ago, the WHO, we found that there was a cesarean section epidemic, especially in Brazil, with a cesarean section rate of 80%. So 80% of women were undergoing cesarean section then. And the primary cesarean section rate, that means every time a woman has a cesarean section for the first time, should ideally be less than 10%, maximum of about 15%. So how can the cesarean section rate, like at consent, when the woman wants it, are we allowed to refuse it? Isn't that the question? Which, as Dr. Manju has very, very clearly said, we have to get something like an informed consent, explaining everything to the patient. And it also depends a lot about the money and the insurance involved. Like if it is being covered by the insurance, some of the insurances refuse to cover it if it's being requested by the woman. There has to be a medical indication for a cesarean section. I think if the fright behind undergoing a normal delivery is removed, possibly more women would be, more willing to go ahead with a normal vaginal delivery. If my colleagues here, the doctor, they are terrified at taking OB-GYN just because of what they went through during their undergraduation or their posting in the labor room. All of us can very well imagine what a woman would be subjected to, listening to all the rumors, all the horrors, apparent horrors that are happening in the labor ward, and she wouldn't want to be a part of it. If respectful maternity care is being assured for a woman, I'm sure she would very willingly want to go through labor.
Thank you, Minnie.
Well said, yeah. It is, I think, very well said, Minnie. I fully agree with what you say.
Yeah, Aparna, you wanted to say anything about that?
Yeah. No, I agree with Dr. Manju Puri and Dr. Minnie that, I think it's the counseling. And we are somewhere lacking if we say, and we have to really, when we say informed consent, we have to present the other side. The problems with the cesarean, and that is not being in our practice. I don't think if we are actually counseling, and the fear of labor, if we are dispelling that fear, we will not find as many elective cesareans that we are finding now. I think that is where we need to work on. And somebody has actually said that, can we pass on to a colleague if we are not, agreeing to the idea with the patient? And I think that is very much relevant with the abortions and MTPs that are happening these days, that if somebody is not really agreeing to do an abortion, we can, that is a personal choice to be done. But as far as cesarean is concerned, I think we must first fully counsel on the other side. If there is no indication, we really need to counsel.
Yeah, so of course, the extreme case which somebody brought up on the chat box is this, for want of a better word, muhurat cesarean, or what, all kinds of times of the day and night where the facility is stretched to its limit, and we don't have adequate people. We have juniors available at night, and so many things. So the respectful maternal care, the objective is something else. And very much the need of the hour, and something should have happened 100 years ago. But at the same time, how do we stop it from being misconstrued as the patient can ask and get whatever they want? I mean, the mother or the family or whatever. So, Minnie, you had your hand up?
Yes, there is one thing that, starting from the top, right from the top in the government, we should actually do is to have courses on respect starting from undergraduation. In fact, it should be inculcated from schools. And as a medical fraternity, I think we are receiving the public's ire for what they understand as misbehavior or misbehavior from the doctors or wrong judgment from the doctors. This can be overcome only if we teach respect, and this should be taught in medical college. Many of us come from diverse backgrounds. We have diverse methods of communication. I think all of us need to understand that this is the way that we should behave. This is the way this should be taught. I'm sure that if this can be done, maybe in 1 or 2 decades, we won't be talking about respectful care at all, because that will be the norm.
Yeah, so hopefully the journey that has started with the laboring mother actually cuts across all specialities and everything, because respectful care is it's the right of any patient or any client or anybody, right? It's not just the birthing mother. So we haven't even got it sorted out in all the other specialities. And I'm sorry to say that just because the institution is private or the care is paid does not guarantee respectful care, whether it's obstetrics or otherwise. I have been in the system of private care for close to 30 years, and it's shocking. But just because the care is private or patients are less doesn't guarantee respectful care or all the components, the informed decision making, consent for everything and anything. So most of the institutions are putting, standard operating procedures and trying to put all these systems in place. But like Madam said, even simple thing like having a birthing companion is not actually the 100% of the time, even in the private setup. And I've come to know only today that it's actually a law or it's a legislation. So we can't just dump everything that goes wrong happens only in the public sector. Not true. There's a lot of stuff happening everywhere in all private sector, corporate sector, the works. So we have my colleague from Fortis Bangalore, Dr. Gayatri Kamath. Gayatri, would you like to say something?
Yeah. Apologies, I joined a little late. I'm sorry for that. But if I have to say, I think our postgraduate education in the labor wards is a little different from what we really practice, because the numbers are so overwhelming that the element of empathy is grossly neglected, because there are huge numbers in our government hospitals. So it becomes a very mechanical event, and we forget the emotional aspect of a laboring woman. So in my practice, as I evolved from postgraduate to become a consultant, this slowly sank in that we are becoming very impersonal to women in labor. So that is when this respectful care comes in. And when you go through labor, it becomes all the more clear that how we need to, when we are on the other side of the table, things really sink in. So I feel when we are imparting education to our postgraduates, it's important to, emphasize how the patient feels and how to make them most comfortable. In my practice, I have been doing this involvement of the partner in labor, and it has helped very much in progressing towards a normal labor, because there is somebody from their team who helps them to support. I mean, that makes a remarkable difference. And even the RCOG states that having a supportive partner is one of the key elements for a blissful normal labor. Regarding on-demand C-section, I fully agree with my colleagues here that we should put the other part of the story as well, because they hear a lot of stories. And what I do in my practice is, we have a bunch of people who have gone through normal labor and who sing the laurels of normal labor. We call them support groups for normal labor. So we generally tend to make people interact, people who have delivered normally, so that they try to encourage the others. And we try to give patient information leaflets on the pros and cons of C-section when they decide to choose a C-section. And I have some videos to just explain and address fears during labor. So all these can go a long way in trying to dissuade people for no indication C-section, the maternal request C-sections. So I think this is where all of us, whether be it in the private or public sector, we need to play our role in spending some time and trying to explain the both sides of the coin rather than just going as per their wishes. I wish I was a little early. I missed a large part of it, but I'm definitely going to look at the recorded version.
Radhakrishna, you did that long write-up, which I have promised to share with Aparna and Manju and Mini. Was this what you thought the session would be when you wrote your introduction this morning?
No, actually, I'm ignorant. I haven't heard of this word. Actually, I have no idea. But I also felt good that my gynecologists in my place where I work also haven't heard of this. I mean, I'm surprised that they are not. They asked me what is this respectful maternal care. I got shocked when I was reading words like obstetric violence and stuff like that. Then I just want to see what is it all about. Is it the violence from the medical fraternity or whatever? Anyway, it's a wonderful talk, and actually I'm really overwhelmed that the two of the senior most persons in the biggest hospitals in India are in the forefront working on this, and I have great respect for you both for doing a wonderful thing like this. And actually, I should say I share my feelings with Ilango when he said that this toxicity, etc. The thing I notice, especially in public sector, is not just the doctors, the lower grade employees, the way the expletives they use and the words and the hitting, the screaming, it's really, really pathetic. Actually, I thought it's a way of life. It's like jailers treating some petty criminals in jails. That's the way it used to be. And sadly, the women, and once they see the baby, they're happy, they forget everything else, and they don't talk about it. I think that is the only way these things don't come out in the open. It's a wonderful, wonderful subject, wonderful topic, and as Dr. Mini rounded up, I think this respectfulness should percolate to everything else. We do many things as surgeons and physicians without telling the patient what we are doing. And this rudeness is not just OBGYN, it's all over. I'm sure the youngsters, the students, the MBBS students, nursing students, and even other hospital staff should be taught this in a very, very strong way. Great session, great talk. And, once again, my kudos to Dr. Aparna, Dr. Manju Puri, and Dr. Mini Ravi. Thank you so much.
We are kind of out of time. So unless Dr. Aparna, Dr. Manju, you have some closing comments, get ready to wind up.
So from my side, I think we all need to take it forward. So irrespective of specialty, I think very valid point made that, we are inherently rude, if you ask me. If you go abroad, we only would behave in a very different manner because everyone else is behaving in a different manner. So somewhere down the line, I think someone had made this comment that we need to inculcate this culture right from the childhood. And, we as quality people, Aparna and me, would say that we don't look at what others are supposed to do. We look at what we can do. So we as obstetricians can definitely make an impact as to, when the students come to us, whether, there's a first time when I was taking a class for undergraduates, I talked about respectful maternity, officially as a talk. And they asked me, ma'am, aisa bhi hota hai, that the patients can deliver in any position. They were so kind of, curious to know more about it. And I think we need to introduce it. We need to make more noise. We need to talk about it at every forum and take it forward. I think that is what is my closing comment. I look forward to it. Yeah.
I would just say that, when Tilaka asked me to talk about it, I said, the journey has started. Maybe, I would love to talk about it after 1 year, but she said, no, you should talk about it. But I'm happy that, we shared this idea. And I think this is our first talk, ma'am, together on this. And I'm sure we're going to, have a lot of experiences on this journey together. And we do hope that, we are able to make a difference to the place that we are working in. So this is what we are looking forward to.
Mini?
Oh, it's so nice to hear from people who can really make a difference in, governance and care across the country. And I'm so glad to have been here listening to this happening. I don't know, respect is very important to me as a person, and I think everybody deserves to have this respect. Be it a woman, a child also, a baby also deserves all the respect. And I'm so glad that Dr. Manju and Dr. Aparna to be part of this, to listen to you both, delivering the change that women need in our country. Thank you.
So it's a wonderful way to wrap up this year. Marvelous Medicine achieved the major landmark of having its 100th episode this year, but I think this outshines it because we have been part of something from the beginning. And normally Marvelous Medicine is coming into the picture only after things have already happened. People talk about what they've already done. But here we were able to join you at the beginning of your journey. And like everybody's agreed, it's not just about respectful maternal care, it's about respectful care for everyone. So I'm sure you have lit the spark in many of us. And starting tomorrow itself, I'm sure we will be more mindful about everything that we do. And we will be more mindful about what others are doing around us and try to be more respectful. Thank you so much, and wishing you all a very happy and safe new year. And we'll meet you again next Thursday in the new year with a different episode of Marvelous Medicine, where we'll be having a physician talk about all the non-medical things that she does in life to keep her stress down. So thank you everyone for joining in and making this session so interactive. And it shows that the time has come by the amount of queries and comments that you had on the chat box. We hope to have Aparna and Dr. Puri again sometime in the next year, maybe not only about respectful maternal care, about something else as well. So till we meet again, good night and stay safe.
I'd like to give an applause.
Thank you.
Thank you.
Thank you and good night.
Good night.
Good night. Good night.